Okay, welcome everybody. Slightly later than we'd expected, but welcome. We've got, how many people have we got? We got about 8 or so individuals. Can you make comments, please, in the chat box? I assume everyone can hear me. Yes? Just write yes in the chat box. Yep, that's good. Okay, good. Yeah, fine. That's marvelous. Okay. Are you all coming toward the beginning of your training? I can't remember now, or is it towards the end of your training? I think you're the September, October start. Are you? Yes? No? Autumn start. Okay. Marvelous. Okay. Well, I do so many of these lectures, I can't recall which ones I've done and which ones I haven't done, but it doesn't matter. They're all a learning process. So what I hope to do is go through a series of cases with you across ENT. So this will be a little bit like a bad clinic or ward round. So a number of cases. I'm going to do very little of the work. I will pose some clinical questions based on a clinical image, and we'll see if we can't interact and bounce ideas and learn from one another. So let's get straight into the case. Let me just get rid of this a little bit there, up there. That's it. Move this a little bit around there. That's it. Okay, so here we are. This is the appearance of the throat some 7 days after a tonsillectomy. This is a teenager. Can you list 6 symptoms the patient may have and why they are present? So you can enter your answers in the chat box. Once you know 6 symptoms. Pain, okay. Pain, fever, can't swallow, okay. Okay, dysphagia, can't swallow. Anything else? We've a lot of can't swallows. Yep, halitosis, Mahi, that's very good. They may complain bitterly of halitosis. Anything else? Trismus, yep. Anything else? What's the one sign or symptom that might worry you excessively? Remember, 7 days after a tonsillectomy could occur 7 days after any surgical procedure. Anybody? Change in voice. Oh, well, okay. We'll put that down. We'll discuss it in a second. Bleeding. Yes, Talia. You're always worried about a secondary hemorrhage. In all operative procedures, 7 to 10 days after the procedure, maybe sometimes up to 12 days, you may get a secondary hemorrhage. Is there anybody hazard a guess as to why this bleeding may occur at 7 to 10 days? Anybody have any idea? Infection, yes, that's right, Linda. It's usually due to infection, which softens the clots that have occurred over blood vessels, and therefore the clot, once it's softened, might fall off and you might get bleeding. Okay, generally speaking, you may get some small bleeds, okay, and they invariably settle down in sort of 95% of cases. but in a small percentage of cases, between 1 and 5% of cases, it may herald a much larger bleed, a much larger blood vessel where the clot has softened, and therefore you may get a major secondary hemorrhage. So generally, if there's fresh blood at 7 to 10 days, as opposed to a slight tinge, sort of serosanguinous discharge or coughing up, you would really need to get these patients back into hospital. Okay, so we've got a series of symptoms there. Pain was a common one. What's the pain due to? Anybody hazard a guess what the pain is due to? The pain might be in the throat, but it could also be somewhere else. Okay, inflammation, yes, but I'm talking about nerves, Linda. Which nerve supplies the oropharynx, the tonsil and the posterior third of tongue and the oropharynx at the back of the throat? What's the nerve that supplies that area? Anybody? I've used two terms in my last little bit of spiel that should give you a clue. Okay, the ninth nerve, otherwise known as what, Mahi? What's the glossopharyngeal? So it supplies the glossus, tongue, right at the back, and the pharynx, in particular, the oropharynx. That's the bit of the pharynx behind the mouth. The bit of the pharynx that's behind the nose is called the nasopharynx. Behind the oral cavity, oropharynx, and behind the larynx, the laryngopharynx or hypopharynx. So the glossopharyngeal nerve has exposed nerve endings, and so when patients try to swallow, it's very, very painful. Okay, hence the dysphagia. What else why do we get the otalgia or earache? What's that due to? Did somebody mention earache? I don't think anybody mentioned earache. Clearly nothing wrong with the ear. You look into it 99.999% of the time and it's normal. It's referred pain from which nerve, Linda? Anybody hazard a guess? Which nerve supplies the throat and supplies the middle ear? It's pretty obvious. It's the glossopharyngeal nerve. The glossopharyngeal nerve also supplies sensation to the middle ear cleft. Okay, so you get referred pain to the ear. It's always worth looking in the ear if patients are complaining, but invariably the ear is normal. Okay, so the pain in the throat is due to the glossopharyngeal. What's the trismus due to? Inability to open the mouth and chew, and uncomfortable when you chew. What's that due to? Why do you get trismus? Anybody hazard a guess? I mean, it's like a stiff jaw. If you were using your arm muscles or leg muscles, what might that? The muscles are affected. So which muscles open and close the mouth? Besides the masseter, it's the pterygoid muscles. You've heard of the pterygoid muscles? But let me get rid of the dog. He's just chewing. Go on, Axel, out. Out. Go out. Sorry about that. The pterygoid muscles sit in the base of where the tonsil was. So the tonsil has been removed and the pterygoid muscles have bled and they are inflamed and they can't act properly. So it's uncomfortable to open and close and chew. So trismus is quite common. It's not usually severe, but it's quite common. Okay, halitosis. What's the halitosis due to? Halitosis. Yeah, it may be pus collection. It may be infection. It may be just slough and yeah, dead tissue, and it all smells rather horrible. Also, you probably haven't brushed your teeth. You can't gargle very well, so there's lots of old, decrepit detritus lying around in the mouth, which is rather smelly. Generally, excessive halitosis may well imply infection, in which case the patient may benefit from antibiotics. Fever, obviously, if you get an infection. Dysphagia, we've already covered. And what else did we have? Can't swallow. Well, swallowing will mean that the glossopharyngeal nerves are stimulated as the food and drink passes over the tonsil area. So that is rather uncomfortable. Okay. All right. So hopefully most of you got that. The main one is bleeding. Anything where there's fresh blood, which is being coughed up, you probably need to get them back. That is overt bleeding. That's people can see it. You're coughing it up, but patients may well swallow the blood. So be a little bit careful when you look in a patient's mouth or you take a history. If they say I haven't coughed up any blood, it may be that they've been swallowing it all. And frequently you may look inside the mouth and see a large blood clot lying in one of the tonsil beds. If you see that, please get them into hospital because the clot may come off and you may have a major hemorrhage. The number of complications of bleeding, any idea how often secondary hemorrhages occur post-tonsillectomy? Hazard a guess. Yeah, 5%, probably a little bit high, Ruth, but yeah, somewhere between 1% and 4%, depending on who's doing the operation. Okay, you diathermy or tie the blood vessels. If you tie blood vessels, there's less necrotic tissue, less chance of infection and secondary hemorrhage. There's some evidence that suggests that. If you diathermy the blood vessels, which is what I tend to do, you get a little bit more necrotic tissue, and it may be the incidence of post-operative secondary hemorrhage is slightly higher, but you must have judicious use of diathermy. That's not a scorched earth policy, diatherming everything, then you'll almost certainly get a hemorrhage. But if you're judicious, then either tying or diathermy on the tonsil bed leads to probably between 1% and 4% post-operative secondary hemorrhage. So it's not very high. Okay. Good. Any questions on that? Or you're reasonably happy? Either post a question or just say happy in the chat box. Okay, so these are the symptoms that we mentioned. Okay, Linda, you're happy. That's very good. Okay, here we are. This is a coronal section through the ear. Remember, coronal means crown. So you have a sagittal section. Okay. You have an axial section. And then you got the coronal section, a bit like wearing a crown, the way the Queen would wear a crown. So that's a coronal section, okay, of the ear. So I've got there, name the three structures located in and around the inner ear. So we got the outer ear, middle ear, and inner ear. So the three structures there, please. At least three in the inner ear. Cochlea, yep. Anything else? It's pretty obvious, but it's worth making a note of. Okay, the snail or the inner ear cochlea. ET, what's ET? Eustachian tube? No, no, eustachian tube is not in the inner ear. The vestibule, okay, that is in the inner ear. What else is labelled here that's in the inner ear, Talia? Some obvious things. Semicircular canals, balance route, yep. Labyrinth, yep, very good. Anything else? So you've got the hearing bit, the cochlea, you've got the balance bit, semicircular canals. What's this in the inner ear? It's the eighth nerve, which consists of an auditory part, and it also consists of a vestibular part. So the eighth nerve has two parts to it, the hearing part, the auditory nerve, and a vestibular part, which is the balance part. And they obviously take stimuli from different parts of the inner ear. Okay, very good. One other thing, one other structure that passes through the inner ear, but also the middle ear, is what? Without it, you can't smile very nicely. Yes, the facial nerve. Chanel, yeah, Linda, yeah. So if you get a fracture of the petrous temporal bone, this is the petrous temporal bone here, you can get a transverse fracture, which can knock out the vestibular nerve, can knock out the semicircular canals, and also damage the facial nerve in the petrous temporal bone. Okay. Also, you can see if you have disease in the middle ear, then it can very easily get into the inner ear. Cholesteatoma, for example, can get into the inner ear and cause damage either to the semicircular canals or the hearing component of the ear, the cochlea. Okay. Okay, what's B then? Besides the ossicles, what does the middle ear contain? So here's the middle ear. So the middle ear is the bit that you and I think of as the middle ear with the ossicles in it. But the middle ear is really a middle ear cleft. It also includes the eustachian tube here. And not depicted very well here is the mastoid bone as well, the mastoid. The mastoid, the middle ear as you and I know it, and the eustachian tube are all a continuum, and they're called the middle ear cleft. So when you get an acute otitis media, it's not just this part of the ear that's affected. The eustachian tube and the mastoid back here is also affected. So besides the ossicles, what else is in the middle ear? Not necessarily depicted here. What do you find in the middle ear? Oval, okay, right, okay, Mahi. I'll give you that one. Okay, at this end, you've got the oval window and the round window. Okay. Other structures, please. That's going for the full prize, Mahi. Well done. Are there any muscles in the middle ear? Yep, stapedius, which stops the stapes from rattling away when you get a high-pitched sound. Stapedius muscle. Any other muscle? Tensor tympani, Mahi, very good. That tenses the eardrum. Again, if you get a loud noise, it tenses it to prevent too much intensity of sound going into the inner ear and causing problems. So we got ossicles, we got two muscles. What else do we have in the inner ear? What is this cavity full of? Is it a vacuum? What is this? Or is it something else? Anybody? So when the ossicles move, yep, it's air. Well done, Kathleen. So the ossicles are going to move best if there's air in the middle ear cavity, and you know there's air in the external ear canal here. And when the pressures of the air in the middle ear cleft and the pressure of the air in the external canal are the same, the eardrum will move nicely, freely. If you block the eustachian tube with a cold, a tumor, with allergic rhinitis, then this becomes a closed cavity and the air gets absorbed. The pressure becomes negative and the eardrum gets retracted inwards and stiffens. And so there's a conductive hearing loss. That's what you tend to get with colds, and also is a cause of secretory otitis media, because in kids the eustachian tube doesn't work very well and they're liable to have a negative pressure here which sucks in the eardrum, but it also produces excessive secretion from the seromucinous glands. So in the middle ear cleft, there are serous glands and mucinous glands producing mucus. So you get seromucus production. The middle ear cleft really is part of your upper respiratory tract. So it contains serous glands and mucus glands. Okay. Very good. Okay, name the structure that assists equalization of pressure in the middle ear and name one reason this function could be compromised. Okay, well, I've given it away. The eustachian tube is the structure that ventilates the middle ear. So can you think of disorders that might prevent that happening very well? What prevents the eustachian tube from functioning efficiently? In the chat box, please. I've named a few already. Let's see if you were listening. Okay, sinus infections, infections of the nose, rhinitis, absolutely. Tumors of the postnasal space. Yep. Anything else? Any blockage, rhinitis, Chanel, that. Anything else? there's muscles, for example, the levator palatinus that's attached to the eustachian tube. Is there any condition that you know that might affect the levator palatinus? Anything that affects the palate? A not uncommon condition, which leads to usually major middle ear issues. Any disorders of the palate? Yep, Mahi, cleft palate can lead to quite serious issues with eustachian tube dysfunction and major chronic long-term middle ear issues, particularly glue ear, requiring recurrent grommet insertion, which may eventually end up as formal cholesteatoma requiring more extensive surgery. Okay. Right. Name the structure that sits in the space marked X. What sits in there? What structure normally sits in this area marked X? Anybody? What normally sits in this area here? This is obviously the skull base here. This is the skull base. What's sitting in here? Anybody? Brain hemisphere. Okay. Yeah, it's actually it's part of the brain. Usually the temporal lobe sits here, the temporal lobe. The reason for indicating this area to you is you can see that the distance between the middle ear cleft and the intracranial contents is only this roof here, bony roof. And in the old days, when you had quite severe middle ear infections or tuberculosis or extensive cholesteatoma, that would burst through here and cause major intracranial complications. You know, intracranial complications such as what? Can you give me a few potential intracranial complications that might result from middle ear infection? You may get an extracerebral abscess, intracerebral abscess. Very good, Chandler. Yep. What else? Anybody else? What else? What about if you stimulate the covering of the brain? Yes, Linda. Yep. Meningitis. Yep. What about an inflammation of the brain? What's that called? Encephalitis. Yep. You can get thrombosis of the veins in the cranium, lateral sinus thrombosis, for example. Okay. Just excuse me 1 second. I better take that. Hello? Sorry about that. Okay. Now, final question is, how would you describe the shape of the external meatus? the external ear. It's not quite like this, but this gives some indication. How would you describe the shape of the external ear? Quite important when you're examining the ear and maybe doing suction clearance. Broad fan base. We cannot see you, Professor Dhillon. Oh, why is that? I'm not that handsome. Okay, here we are. So broad fan base is sort of funnel shape. Yeah, oh, not quite. So it's not funnel shaped. It's just it's almost a cylinder. Tunnel. Who wrote tunnel? Somebody wrote tunnel. Mahi wrote, oh, funnel. You mean, okay. I thought you said tunnel. Okay, it's more tunnel shaped cylinder, but the cylinder has a dog leg. That's why you need in adults to pull the ear back and up a little bit to straighten the dog leg. Okay, so it's dog legged. That's why if you put the otoscope directly into the ear, you'll hit the posterior ear canal. So you have to pull the ear back and slightly up in order to straighten the dog leg. Okay, so that's very important. So it's dog-legged. That's why when patients clean their ears and they put the matchstick straight into their ear, it hits the posterior wall and causes an abrasion. Okay, they don't know that they have to straighten the dog leg. They think the ear is straight. So the dog leg is important. And what's the other important bit? It's called the anterior recess. See, right at the front of the ear, it's not depicted well here, but you can see it. The ear canal falls away downward. And there's a space between the outer surface of the eardrum and that slope of the ear canal where there's a recess. It's called an anterior recess. And frequently you will get wax all over here and you clear it. And if you're not careful, you look at the ear and the eardrum seems to be clear. But if you move your otoscope around and try and look into the anterior recess, you might find a blob of wax in there or some further discharge, which if you don't clear, will provide the patient with a continued hearing loss. And although you say the ear is clear, the patient still complains they have a hearing loss because they've still got wax in the deep part of the ear and in the anterior recess. So remember, dog leg, anterior recess. Any questions on that? Any questions on the coronal section of the ear? If you're happy and you know it, type it in the chat box, please. Okay, so I've just put the answers there, but you've got all the answers if you've been diligent about writing down what we're talking about. Okay, here we are. So this is a 3-year-old who presented with persistent crying, a temperature, off feeds and tugging one ear, the right ear. So first of all, let's describe eardrum A, the ear not being tugged. Sorry, let's just pretend that's the ear not being tugged. How would you describe ear A? Normal. Okay, who thinks it's not normal? Everybody think it's normal? Okay, if you think it's normal, describe what this is. The arrow is going up and down on. What is that called? What is that little part of this structure? What is this called? You can see some little blood vessels on it. But what is this structure called? Handle of Malleus, yep. Or long process of Malleus. Very good. And what is this knob thing called here that you see? It's the head of the malleus as opposed to the malleolus, Linda. That's putting your foot in your ear otherwise. That's part of the ankle joint. Instead of putting your foot in your mouth, you put your foot in your ear. Sorry, that's fine. Easily done. So what is this little structure here? Lateral process or short process of the malleus. So in a normal ear, you generally see this running in this direction in the right ear, and obviously in the other direction in the left ear. Sometimes you see these tiny little blood vessels. These are normal. That doesn't mean it's inflamed. And what's this here that I'm pointing to here? This here. Well, okay, it's the tympanic membrane, but this is the tympanic membrane here. Tympanic membrane reflex. No, you're half there, Talia. It's like a cone, isn't it? The shape of a cone. And it looks like a cone of what? It's a cone of light. Chanel, yep, very good. It's a cone of light that's reflected in normal ears. You normally see it coming off the tip of the long process or handle of the malleus in this shape. If it's absent or broken up, it usually means the eardrum's retracted inwards. Okay. And then how would you describe the color of the tympanic membrane generally? How would you describe it? So how would you describe the color of the tympanic membrane? Anybody? Anybody hazard a guess? It's slightly gray in color. Gray, and you may have areas, yep, Chanel, that's very good. Grayish, maybe clear and transparent, okay? And you see this white structure here, which is obviously in the middle ear cleft itself. What is this large structure, do you think? This large structure here. Looks bony, doesn't it? Looks like bone. What do you think that structure is? It seems to be coming out at you. It's quite prominent. What do you think that is? It's clearly not attached to the tympanic membrane. It's obviously on the other side of the eardrum, the far wall. What do you think it is? Anybody hazard a guess? Linda, good try. It's not the incus. The incus would be up here. Would be up here. Okay, because you got the maleo incudo, sorry, the incudo-malleal joint is up here. So it's not the incus. Good try. It's a rather large incus if it is an incus, isn't it? It looks rather large. It's called the promontory. I thought I'd given it away. Okay, it's a bulge of the medial wall of the middle ear where the inferior turn of the cochlea is bulging into the middle ear. It's called the promontory. And then if you look directly below it, you get a hint that there is a little niche there. There's some sort of niche. And that is what, do you think? That is the round window niche there. And the stapes, you can maybe get a hint of the stapes there. And the stapes and oval window are going to be here. Okay. And if you look at the wall of the canal where it joins the drum, it's nice and clear. Okay. So this lower 2/3 of the eardrum here, okay, is the mesotympanum. And this bit up here near the ear canal is called the epitympanum. That's mean it's sitting on top of the eardrum. Okay, so that's the mesotympanum, and this is where you tend to get cholesteatoma forming here and then bursting into the middle ear. So this is called the epitympanum, or sometimes known as the attic. In your house, the attic is at the top. So this is known sometimes as the attic. And when you examine an ear, particularly in chronic discharge, you need to examine this area carefully to see if there's any cholesteatoma or crusts forming there, because it might indicate the presence of cholesteatoma. Okay, so this is as Mahi said earlier on, is a normal ear. Okay, describe eardrum B, which was the otoscopic appearance of the tugging ear. And what is your diagnosis? Describe the appearance. Bulging, the eardrum looks nothing like a normal eardrum. It's red, it's angry, well done, Kathleen, red, angry, bulging, all the landmarks, the malleus, the light reflex, the round window, the promontory, the stapes, the attic, have all disappeared, okay? So what is your diagnosis? Yeah, it's otitis media, but what type of otitis media? It's an acute otitis media. Now we caught, yeah, that's well done, Talia. It's an acute otitis media, but remember, it's not just the middle ear as you and I know it, where the ossicles are, but the eustachian tube will be affected, and also the mastoid. It's an acute infection of the whole middle ear cleft, as it's called. Okay. So even the mastoid is affected. It only becomes a mastoiditis when the bone becomes necrotic in the mastoid itself. Then it's an acute mastoiditis. Okay. So that's correct. That's the acute otitis media. Now, what's happened in C, which is eardrum B, some 1 hour later? What's happened there? Yeah, I mean, there's been a spontaneous perforation of the tympanic membrane. Okay, well, that was an easy one. What about number 4? Which features, now think about this carefully, which or what features may be present once C has occurred? Remember, B will produce a certain type of features. We said crying, pyrexia, off feeds, tug in ear, etc., etc. What happens once B has occurred to the child? You get otorrhea, less crying, very good. What else? Less painful, okay. The child may not say it's less painful, but what do they do about tugging their ear? They stop tugging their ear, don't they? Pyrexia might abate, and the child, which was fretful and inconsolable, falls asleep very peacefully. Okay, so once a perforation has occurred, it's usually a good sign. The child is better, the pus has been released. It's very rare for us as ENT specialists to see a child in this condition. It rarely goes this far, and if it does, we have to do what I've suggested, or you will tell me in question 5, how may you treat the child if at stage B? If you meet the child with a bulging eardrum, what are you going to do? Yeah, supportive. What does that mean? Yeah, painkillers. Yep. Would you give antibiotics? Unless bilateral. Well, pain meds. Yep, Chandler, that's good. You may consider giving antibiotics because you're under huge pressure by the mother and father, the parents, on giving more than just painkillers. Once the eardrum has burst, it just means keeping the ear dry and maybe using some topical drops, antibiotic drops, just to help the inflammation settle down sooner. Okay, any questions on that? If you're happy, then just write happy in the chat box, please. You lot are easily pleased, aren't you? Okay. I think we've got most of this. Okay. Same child as the previous one, but was sent home on analgesics, and possibly antibiotics and oral antibiotics, and returned 12 hours later. Now, A, describe what you see. They obviously know better. Yep, swelling of the mastoid. Okay. Well, that's the diagnosis, but what do you actually see? If you have a partner sitting next to you, look behind his or her ear, and normally you see a sulcus, called the posterior sulcus of the ear. The posterior sulcus has been completely obliterated with this swelling. Okay, so I agree. The skin is erythematous, Linda. Okay, and the posterior sulcus is obliterated with this swelling, and the ear looks as though it's been pushed outwards and slightly downwards, which is what tends to happen with an acute mastoiditis. Okay. Occasionally, and I don't know if it's clear here, you may see some discharge in the external meatus as well, but that's not invariable. If the infection hasn't caused a burst eardrum, which may be unlikely if they've got an acute mastoid, then you may see no discharge. But they may have a mastoiditis, and then the eardrum bursts afterwards. Okay, so loss of posterior sulcus, and the ear position has changed. In the adult, you will get this to some degree, perhaps not so bad, but if you put your little finger into the boat bit of the ear, just above the ear canal, where you feel the bone, it's called McEwen's triangle. And if you press on McEwen's triangle, it's exquisitely painful in adults with acute mastoiditis. So it's just above the ear canal. There's a little gap between the cartilages there, little ridge, and then you press on that, you can feel the bone. That is McEwen's triangle. Okay, McEwen Scottish. There's also a McEwen bitter for those that are interested in beer. Okay, but I don't think it was the same McEwen who made the beer who described McEwen's triangle. Okay. Okay, so name other clinical features. These are the features that you see. What else in terms of clinical symptoms and signs might you find? And I've mentioned some of these already. What other clinical features are there? Crying, yep. Inconsolable child. Fever, headache if they're old enough to describe it. They'll have a fever. And it's bloody tender, as I said to you. If you touch that, it's extremely tender. And you may have the otorrhea, all right, a flow from the ear, otorrhea. So the diagnosis, we know there's an acute otitis, an acute mastoiditis. Name two complications of this. And if you were listening earlier on, you can very easily name two. Meningitis, yep, it goes into the cranium. Cerebral abscess, yep, we used to see this, not in my time. Antibiotics have pretty much eliminated this, but 70 or 80 years ago, you would have a whole list of mastoidectomies at the end of the day when you finished your job as a registrar, with these kids lined up to have mastoidectomies in the evening. Okay, meningitis, abscesses, cerebral abscesses, etc. So what are the management steps here? What are you going to do? If you're in GP land, what are you going to do, and what do you think the secondary care will do once you have clearly you're going to get them into secondary care. You won't manage this. How do you think it's managed? Urgent ENT referral, yep. And what do you think they're going to do, Linda and the others? High dose intravenous antibiotics. What about observations? Very important. Because if they don't have complications, they may develop them before the antibiotics have had time to work. Frequently, if you give high dose intravenous antibiotics, you can avoid an operation, but you need to monitor the child very carefully in terms of pyrexia, alertness, and any intracranial complications. If you're concerned about NeuroWatch for seizures, yeah, NeuroWatch generally, Kathleen, that's a very good idea. If you suspect intracranial issues or nearing them, what do you do? What would you order? What would you order? Neuroobs, yes. What about imaging? CT brain, yep. You do a CT scan. So you've got a baseline to work on. And if the antibiotics don't work, or the patient progresses, or there's a intracranial complications, you're going to have to go in and clear the infection and do a cortical mastoidectomy, it's called. So it's like coring, you know, the crunchy bar. The chocolate is the skull base, and the mastoid is the honeycomb. And what you're basically doing is clearing out the honeycomb and all the necrotic and abscess material that is replaced the honeycomb before hopefully it's burst the chocolate. Okay. Any questions? If you're happy, or if there are any questions, in the chat box, please. Yeah, Kathleen, CT brain. This was some of the answers that I had. Everybody happy? Any risk of thrombi? Yeah, there's a risk of thrombus if you get an intracranial complication, Kathleen. Okay, so meningitis, lateral sinus thrombosis, that's a possibility. It's rarely seen nowadays, but that doesn't mean to say it never occurs. They were 2 a penny 50 years ago, 60 years ago. So you just have to be mindful that if the child is deteriorating, is there a complication developing? And thrombi only if the infection goes beyond the bone into the intracranium and into the venous channels. There's a risk of thrombi. Go on, Axel, get down. Right, everybody happy? And if you want one more scenario, we can do one more, otherwise it's 2 o'clock. Do you want another scenario? Please write yes or no, and we'll go with the majority decision. Yes, yes. Oh, okay. Gluttons for punishment. Okay. All right. Everybody. Okay. Let's do one more then. Okay. This is a 25-year-old who presented with 2 days of severe sore throat, dysphagia, pyrexia, and progressive breathing problems. Okay. Now, there are 3 different conditions here that could present with something along those lines, with those clinical symptoms. Okay, name the 3 conditions depicted. There's A, and that's obviously an endoscopic look at the larynx here. So if we just go to A first, what does this image AA indicate? What is that? Well, okay. This image on the left, the A, Kathleen, is a normal larynx, normal appearance. Yes, Chanel, that's absolutely right. I think you mean the one on the right, Kathleen. So on the left, what you can see is the true vocal cords here. You can see the false vocal cords, these bulky things here. The arytenoids, these little lumpy things here. You can see the epiglottis here. And the tongue is here. And between the tongue and the epiglottis is a valley or vallecula here. And this here is the upper end of the pharynx, okay, or esophagus, the piriform fossa. So food and drink goes down in here and here. Sorry. So food and drink goes down here. So if you have a foreign body in your gullet, all the saliva accumulates here. If you have a tumor in the gullet, then saliva will accumulate here and overflow into the larynx, leading to cough and things. So this is a normal larynx. And if you look at this larynx, as Kathleen has said, the epiglottis is enormous, absolutely enormous. So anything above the glottis, the vocal cords are the region of the glottis. Anything above that, the false cords and the epiglottis, is called the supraglottis, or in the old days, epiglottis. So this is an epiglottitis, or the modern term is supraglottitis. Okay, a supraglottitis. Now, what about B? B is looking into the mouth. What do you think B is? You see a structure here, a structure here, a structure here, and a structure here. Peritonsillar abscess, Kathleen. That's very good. So same symptoms, but when you look in the mouth, this is what you see. So that's a normal left tonsil. This is the tongue. That's the palate up there. You can just see the teeth. And this tonsil is very swollen, looks angry, and it's pushed the uvula, see the uvula, to the contralateral side. Okay, so this is a tonsillitis, a unilateral tonsillitis, likely to be a peritonsillar abscess, or what we sometimes term, if it's not that bad, a paratonsillitis. And what about this one here? What do you think this is? What's a T tonsillitis, Shanice? Bilateral exudative tonsillitis, yes. So it could just be a sort of streptococcal common or garden tonsillitis, but in a 25-year-old, what might you think of over and above that? What type of tonsillitis, possibly? Particularly if you get excessive slough, huge amounts of slough on the tonsils. Yeah, you might get a glandular fever tonsillitis. Absolutely. Okay. So which of these needs admission? Supraglottitis, peritonsillar abscess, severe. A, yep, I agree. Any of the others? C, yes, Talia, I think all of them need it. If they got dysphagia, pyrexia, sore throats, breathing problems, progressive, they need to come in. Okay, yeah, very good. Okay, how do you manage A? They're sort of being managed here, isn't it? How do you manage a supraglottitis? Yeah, you have to secure the airway. So they need to be admitted. You need to secure the airway, which is what's happened here. They need antibiotics. They may need intravenous steroids to try and reduce the swelling. And obviously they need pain relief. What about B? How do you manage B? Aspirate. You could try and aspirate that. You mean just a needle aspiration under local anesthesia, which you can sometimes do in the clinic? Yeah. You could do that. Anything else? Frequently, you just get blood, but they've got... Yeah, antibiotics, incision and drainage, possibly. In my experience, if you bring them in early enough, and even if it looks like it's almost pointing, you can give them a trial of high-dose intravenous antibiotics and pain relief, rehydrate them, and usually you don't need to do anything like incision and drainage. It's a long time, touch wood, since I've had to do that for a paratonsillitis or a peritonsillar abscess. Antibiotics seem to be extremely good in this. There will be a handful that require incision and drainage. What about C? How you manage C? So glandular fever, tonsillitis, how are you going to manage that? Anybody? Yep, antibiotics for supra-added bacterial infection, that's good. Analgesics. I'd be reluctant to do an elective tonsillectomy. In the old days, we might, but even for a peritonsillar abscess, once an individual has had it, we would list them for surgery. But the recurrence rate is minuscule, so we don't, unless there are other reasons for doing a tonsillectomy. So for glandular fever, it's antibiotics for supra-added bacterial infection, analgesics, and you just need to monitor them. Sometimes with glandular fever, the virus can cause liver damage. You've got to be careful of that. But otherwise, steroids may be required to reduce the swelling if there's a breathing issue. But they need a few days in hospital to tide them over. And then it just takes a bit longer for glandular fever to recover as opposed to an ordinary bacterial formal tonsillitis. We all get very twitched about post-glandular fever, depression, and various muscle aches. It only happens in a very small number of people. So I generally reassure individuals that they're unlikely to have any medium to long-term issue. Okay, so same symptoms, 3 different conditions. So always be aware. The symptoms are important, the differential diagnosis is important, and then the physical examination will generally help you confirm which of the differential diagnosis is most likely. Any questions? If you're happy, write happy in the chat box. If there are more general questions on ENT, in the chat box, please. Otherwise, I hope you enjoyed the last hour or so. I most certainly did. I hope you learnt something, and it will hopefully spur you on to learn more about ENT and to practice a higher standard of ENT for your patients. So good luck in your continuing education and your little tests and exams. I'm sure I'll be meeting you again soon. I've got several of these prepared over the coming months. So thanks very much. Bye-bye.